You're on live, sir. Please go on.
Good morning, everyone. Welcome back to Sankara Academy of Vision's 2020 series on World Sight Day. Now we have Dr. Padmaja Shankridurg, who is a graduate from Elite School of Optometry. She was, both of us were batchmates in the optometry program. Then she went on to Australia and completed her PhD. And now she's the biggest name in myopia, though she's not myopic about anything, and she has lots and lots of awards and accolades to her. You can read them on her slide, because if I go on about it, it'll take me another 20 odd minutes. So the only thing I want to tell is yesterday she was awarded the International Optometrist of the Year 2020 award in Spain. And she will be talking on myopia, a global public health issue. Over to you, Padam.
Thanks very much, Adi, for that introduction. Good morning, everyone. Firstly, thanks to Sankara Academy of Vision for inviting me to be part of the World Sight Day celebrations. And thanks to all of you for tuning in to listen to me. I'll be speaking on myopia, a global public health issue. I have disclosures to make before I get on to the talk. I'm an inventor on patents and patent applications related to myopia control, and my employer, the Brian Holland Vision Institute, has commercial interest in this space. They say a picture says 1,000 words, and this picture is self-explanatory. This is of 10-year-old children from a primary school from Ho Chi Minh City in Vietnam, and you can see that more than half of them are myopic. And here's another one, and this is particularly relevant for us in the profession. This is the incoming class of optometry students, the first school of optometry at the Ho Chi Minh City in Vietnam. And again, you can see that there is a clear need for the profession. Now, in India, when we look at the prevalence of myopia reported out of India, in the late 90s and the early 2000s, it was said that the prevalence of myopia was quite low. And that's the panel to your, when you're viewing the screen, that's the panel to your left, and it was less than 10%. Whereas more recent studies, including the studies that we at BHVI conducted, we find that the prevalence of myopia in children aged 12 to 13 and above is somewhere in the region of 30% and above. So that's quite a substantial rise in the prevalence of myopia. And here's another one. This is an image of 7-year-old school children undergoing a school screening program. And again, from what you can see from this little snapshot, you can again see that more than half of them are myopic. And I have a little video from pediatric ophthalmologist, Dr. Jiangfen Zhu from the Shanghai Eye Disease Prevention and Treatment Center. And in this little video, what he talks about is the way the myopia profile has changed over the years that he has been in practice.
我是朱建凤医生，那么我的这个眼科医生生涯已经有18年。刚做医生的时候呢，我的主要的患者是初中和高中生。那么这时候呢，做近视门诊呢，主要的年龄都是在12岁到15岁之间。那么这几年呢，随着儿童我们上海的这个儿童近视发生的低龄化的趋势，我也发现我的门诊的病人呢，年龄逐渐呈低龄化的趋势。那么大部分的病人都集中在小学的3年级到5年级之间。那么甚至于我还发现有一部分的儿童那么在学龄前就已经发生近视。这个比例呢，我感觉也是越来越高，甚至于有一些在学龄前已经发展到500-600度的高度近视。我是朱建凤医生，那么我的
So summarizing all of the information that we have, when we consider the prevalence of myopia, especially in East Asian countries, what we see is that more than 50% of 10-year-olds are myopic. So what we have on the slide is data from China, Hong Kong, and Singapore. And you can see that more than 50% of the kids are myopic. Now, what does that mean for other ethnic populations? And I tried to summarize the data in this particular slide using the evidence that is in the literature. And if we were to consider 12-year-olds, and let's say, we talk about 10, 12-year-olds, then we see that in the East Asian countries, approximately 6 to 7 of them are myopic. In the South Asian countries, that's us, when we look at the data from before, as I mentioned previously, the prevalence was quite low, but more recent data seems to be pegging the prevalence at a much higher rate. And we would say about 2 to 3 of the 10 kids will be myopic. The least prevalence is in children of the African ethnicity. And again, European population, we are looking at roughly 2 of 10 kids being myopic. So we at the Brian Holland Vision Institute, what we did was to gather all this evidence, and we calculated the current prevalence, and assuming that the risk factors continue to remain the same, we tried to project the estimates into the future. And this information is not new. We published this a couple of years ago, and based on the evidence, the data indicates that at the present time, approximately 1 of 4 are likely to be myopic. And if the trajectory were to continue, the data indicates that by the year 2050, nearly 1 of 2 will be myopic. And more importantly, the data also indicates that 1 of 10 will be highly myopic. That's myopia worse than -5 diopters. And I'll talk about high myopia in a little while. But what does this mean? The potential consequences of this rising burden of myopia are many. The first consequence is that as a result of the rise in prevalence of myopia, the prevalence of uncorrected refractive error will also rise. And as you can see from these 2 tables here, uncorrected refractive error is one of the leading causes of blindness and the leading cause of moderate to severe vision impairment. And in spite of the Vision 2020 and the right to sight, you can see that from 1990 to 2010, the prevalence of uncorrected refractive error has not changed much at all. And what we also did was to try and estimate the loss associated with the burden of vision impairment from uncorrected myopia as well as myopic macular degeneration. And just for 1 year, that's 2015 alone, it was a staggering $250 billion. The second potential consequence of this rise in prevalence of myopia is that there's going to be an increased need for refractive services, need for optometrists, opticians, ophthalmologists, as well as a need for corrective devices, spectacles and contact lenses, and specialist services, retinal specialists that can manage the complications associated with myopia. So that's projected to rise into the future. The third potential consequence of this rise in prevalence of myopia is that a number of families, an increasing number of families and individuals are going to face costs associated for myopia, as well as they're also going to face quality of life issues. And there's not really good data in terms of lifetime costs of myopia at the present time. And there's one study out of Singapore that has looked at direct costs associated with myopia. When I say direct, it's the cost associated with the person going and seeing a practitioner and the cost associated with optical devices as well as any complications. It does not take into account any loss of productivity. And that was estimated at approximately $17,000 US. Now, I said previously that by the year 2050, approximately 1 of 2 will be myopic and 1 of 10 are likely to be highly myopic. Now, interestingly, the rise in the prevalence of high myopia is sort of disproportionate to the rise in the prevalence of myopia. It's much higher than the rise in prevalence of myopia. Or in other words, more people are going to end up becoming highly myopic. And when we look at the evidence, we can see that already in many East Asian countries where, the prevalence of high myopia is now in double digits. You're looking at anywhere from 12 to 25% of the population having high myopia. So why is it that there is this increasing prevalence of myopia and particularly high myopia? With respect to high myopia, we think there are 2 reasons that are responsible for this rise. One is what we call age-related progression, and I'll talk about that, and an earlier than onset of myopia. So looking at age-related progression of myopia, what we found in the studies that we conducted, and many others have since published as well, that the annual progression seems to be much higher in a younger myope in comparison to an older myope. So in this chart here, which is representative of the progression that we see in the East Asian children, you can see that the 7-year-old is progressing by approximately 0.9 diopters, and in comparison, a 12-year-old is progressing only by about half a diopter. So that is one thing that we have to keep at the back of our mind, that the younger children are going to progress much faster in comparison to the older children. The second thing is, I showed this slide previously. I'm not sure if people are able to see my pointer on this slide here, but generally what the slide, what the graph to your left shows is that between the ages of 3 and 6, you can see that there is prevalence of myopia ranging anywhere from about 2 to 8%. So what we are finding in the studies that we are doing, especially in the Southeast, in the East Asian and some of the Southeast Asian countries, is that we are beginning to see an earlier onset of myopia. Preschool children, children as young as 3 to 4 years old are becoming myopic. And what does that mean? So you have an early onset of myopia, and then we know that there is this age-related progression where the younger children are likely to progress faster. And the fact that you have an early onset myopia means you're also likely to stay in the progression mode for much longer. So a child who has an early onset of myopia is likely to end being much more myopic in comparison to a child who has an onset of myopia at a later stage. So we have the BHVI calculator, which is a simple practitioner tool that will help you understand based on the ethnicity what the final progression of the net myopia is likely to be. So for a 6-year-old, if we do nothing, it predicts that by the age of 17, this child is likely to be about 6.75 diopters. Whereas if there was onset of myopia at 12 years of age, you can see that the net myopia is less than 3 diopters. So high myopia is a problem, and we're noticing from the figures that there is likely to be an increase in the prevalence of high myopia. So what are the consequences of high myopia? The first one is vision impairment. The data that I have here is from studies from Europe, and what they simply say is that in older individuals, because high myopia, I sort of liken it to diabetes. You have it at a certain age, but you're likely to see the complications, especially in later life. So with myopia, the complications are likely to be seen in adult life. So what you see is that with myopia of 6 diopters or worse, an axial length of 26 millimeters or worse, you can see that the prevalence of vision impairment rises quite substantially. Now, in a study that we conducted in association with Zhongshan Ophthalmic Center in China, what we found was that in spite of no retinal pathology, increasing levels of high myopia were associated with mild to moderate vision impairment. When we talk of mild vision impairment, we are talking roughly 2 to 3 lines loss of vision. So these are high myopes who are experiencing 2 to 3 lines loss of vision in spite of having no ocular pathology. We don't fully understand the reason why they're having this loss. It could be because most of the high myopes tend to wear spectacle lenses, and we know that there are problems such as magnification associated with spectacle lenses. Or it might be to do with the retinal surface, the stretched retinal surface, and probably to do with the density of the photoreceptors on the stretched retinal surface. That is not known, but what we are finding is that high myopia is associated with mild to moderate levels of vision impairment. And it is quite well known that high levels of myopia are associated with significant sight-threatening complications such as myopic macular degeneration or chorioretinal atrophy. It is also commonly known as, then cataract, glaucoma, retinal detachments, and so on. And we also estimated the prevalence of blindness and vision impairment due to myopic macular degeneration. And our estimates indicate that it is likely to rise from about 10 million individuals being affected in the year 2000 to nearly 55 million affected by the year 2050. Although I did say that high myopia is associated with complications in adult life, it is also associated with complications in young. If we look at the reasons for pediatric retinal detachment, and here I've got a table which shows the reasons across a number of different countries, you can see that myopia worse than 4 diopters is one of the leading causes of pediatric retinal detachment. So it causes a problems. Any level of myopia is an issue. Higher levels of myopia are likely to cause higher burden due to such complications, both in adults as well as the young. So what exactly causes myopia? We know that the burden is quite substantial, the impact is significant, but what is causing myopia? Even though we know that both nature as well as environmental factors are involved, the evidence indicates a strong environmental influence. And on this slide here, I've listed some of the risk factors. This is not an exhaustive list, but they are the common risk factors that are associated with myopia. And I've sort of divided them into what I would call demographic or patient-related risk factors at the top and environmental risk factors at the bottom. So age, ethnicity, gender, you know, they're all biometric data. But when we look at the data a little bit more closely, it appears that many of these factors are very likely to be surrogates of time outdoors and time spent indoors or doing near-based activities. For example, if we take urban-rural divide for myopia, we know that there is more myopia in urban areas in comparison to the rural areas. It might simply be reflective of the time spent outdoors. It is likely that those in the rural areas spend more time outdoors. Similarly, if you look at the socioeconomic status, higher socioeconomic category, people are more likely to be living in urban environments and they're more likely to be doing near-based activities. Gender, females are more likely to be doing near-based activities. Ethnicity, again, we know from what we are looking at, East Asian populations tend to place a lot of premium on educational pursuits and academic excellence. So they tend to be doing a lot of near-based activities. So it does appear that there's something in there that seems to be more tuned to the amount of outdoor time you have and the time spent on near work activities. Some of this is coming to the fore, and this is work that we are doing in collaboration with Shanghai Eye Disease Prevention and Treatment Center. So if you take an child of a certain age, so here we've got a 10-year-old child, on the just on the basis of the school cutoff criteria for entering school, a child who is born before September is likely to enter the school in a given year, whereas a child who is born after September, they will have to wait another year to enter school. So if you take these two kids, 10 years of age, the one who is born pre-September is in a higher class at school. And what we are finding is that even though they're similar in age, those who are born pre-September are more myopic in comparison to those that are born post-September. So at 10 years of age, there is 0.3 diopters of difference between these two kids. And by the time they're 14, you can see from the graph there that it is as much as 0.7 diopters. Now there's three, I would say, in terms of outdoor, the role for outdoor is pretty much cemented from what I call 3 lines of evidence. The first one is actually the one in the middle graph from Sydney Myopia study. And what they said was that in comparison to a child who has low outdoor and high indoor, that's the comparator, those who spend more time outdoors are at much lower risk of developing myopia. So that was the first one. The second one is evidence that seems to indicate that the rate of eye growth is lower in summer months in comparison to the winter months. And one of the popular hypotheses around this is that it's likely linked with the outdoor activity. And the third one, interesting one, even though it was the one that was published early on, is that in spite of a child having parental myopia, so we see that in that graph there with the dashed bars. So usually a child with parental myopia, the odds of them becoming myopic are higher. So in spite of the child having parental myopia, if they spend enough time outdoors and 2 hours per day, so here we've got 14 hours, 2 hours per day, then they're able to reduce their risk quite significantly. So outdoors seems to be protective for myopia. And that brings us to a discussion of what's happening at the present time, because given COVID, everybody is at home, especially the kids, and they're spending a lot of time on gadgets. So everywhere we look around, people are asking the question, what does this mean to the eye health of kids? There's not much data that is out there at the present time. It's it might slowly trickle in, but there is this publication out of China that says that during COVID, myopia rate increased quite significantly. They talk about 12% increase in myopia. So that's something that we have to keep tabs on. So what can we do to reduce the burden of myopia? In this graph here, we've got in the blue is the refractive error distribution of approximately 6,000 children from Shanghai. And you can see that this was taken in 2016. And at that time, when we look at the blue line and we look at 5 diopters and worse, only 3% of them were highly myopic. And this graph tells us that if we do nothing and if we let the children progress, then in 7 years' time, the prevalence of high myopia is likely to increase from 3% to 23%. So a 7-fold increase in the prevalence of high myopia. So there's 2 things that we have to take action on. One is to try and prevent myopia in those that are not already myopic. And if somebody is already myopic, you've got to find ways to slow the progression of myopia. So slowing progression of myopia, there's a lot that has been done just in the past 2 decades, and that's a lecture by itself or many lectures by itself. It would suffice to say that there are a number of interventions, optical, pharmaceutical, that can slow the progression of myopia quite significantly. Atropine is the only pharmaceutical strategy that is available. Contact lenses, there's 2 contact lenses specifically devoted for myopia. One is MySight from Cooper Vision. The other one is called Milo, an extended depth of focus contact lens that's available in Europe. Spectacle lenses, up until recently, they did not show good efficacy, but a new type of spectacle lens, which has got multiple segments, is showing quite significant efficacy. Hoya has got a product called Myosmart, and more recently, Essilor announced the results with a lens called Stellus, which again is showing high efficacy. So what about those that are not yet myopic? In children that are not yet myopic, you're basically looking at community-based interventions and interventions aimed at changing the behavior or the lifestyle pattern of these kids. We conducted a meta-analysis where we simply reviewed all of the literature to try and understand what outdoor time does to onset as well as progression of myopia. So if we look at the onset, what you see is that there seems to be a nice dose-dependent response. And again, we get to the 2 hours per day time point. So if a child spends approximately 2 hours per day outdoor, then the risk of having myopia is quite significantly reduced. You can see from 1 to about less than 0.4. Surprisingly, we did not find an effect of outdoor time on progression of myopia. So it means that if a child is already myopic, spending more time outdoors wasn't doing much good for them. We don't really understand whether the mechanisms are different between onset of myopia to progression of myopia and why we're seeing that, but that's what we found. To try and understand this better, we actually we conducted a randomized clinical trial in collaboration with groups in Shanghai, and they randomized kids in school to two groups, one group receiving 40 minutes and the other group receiving 80 minutes to try and understand if improved outdoor is going to give us any better efficacy. More importantly, in this trial, we are monitoring the outdoor time and light intensity using a watch wearable. You can see that the kids are all wearing watch wearable, and that will hopefully shed more light on whether it is outdoor time or light intensity and whether it's got a role to play in progression of myopia as well. So I want to finish with this slide. I've got a summary slide. So we are moving from trying to understand the impact of myopia, and we know that it's quite substantial, to interventions. We now have a suite of interventions that can significantly slow the progression of myopia. And we now have to take this to the practitioner who is going to manage the kids. And in terms of the practitioners, they don't have sufficient tools to manage the myope quite effectively, or in the sense, some of them have at their disposal things like autorefractors, whereas we know that if you're doing orthokeratology, you would have the need to monitor axial length. So I just wanted to say that this field is rapidly evolving, and there is a new suite of instruments that will allow you to measure both refraction as well as axial length in a single touch of a button that's coming in. And we are involved in trying to understand the normal growth patterns of the eye. So we've developed a percentile charts that has gone into one of the instruments, and that will allow us to track the progression of a child's eye growth. So in summary, what we're seeing is that there is very high prevalence of myopia in Asian and East Asian countries, but elsewhere the prevalence is on the rise, and it is estimated to affect nearly 50% of the global population by the year 2050. And we are finding that there is a disproportionate increase with much higher prevalence of high myopia, and that is an issue because we know that there's a significant risk of vision impairment and eye disease with high myopia. And we can try and reduce the burden, and we can try and change the trajectory by delaying or preventing the onset of myopia. And we saw that time outdoors was the means that is available to us at the present time. And it appears that having 2 hours or more of outdoor time is likely to reduce the risk quite significantly. And for those that are already myopic, there's a number of interventions that are available. And in addition, it looks like there's going to be a number of other tools that will help manage the myope much better coming into practice fairly soon. And with that, thanks very much for your attention, and thanks for listening to me. Thank you. Bye-bye.
Thank you, Professor Padmaja. We have a couple of questions, if you would be okay to take them.
Sure.
So Himanshu has asked whether there's any association of high myopia with glaucoma, and if so, what type of glaucoma is commonly associated with high myopia?
Yeah, there have been some studies that have reported that high myopia is associated with glaucoma, and they mainly talk about open angle glaucoma.
So our own experience has been quite good with atropine. So we had one of our postgraduates actually do her dissertation on that.
Right.
What we also found, and again, something that we published, is that in children on low-dose atropine who are spending outdoors, we found their progression to be far even lesser compared to those just on atropine. So I think it's very critical. So my question to you is, during the pandemic, when most children are indoors, have you noticed an increase in the progression, so to speak?
Yeah, I actually had a little bit of information, and for lack of time, I didn't put that in. So there's a couple of things that I just wanted to talk about. So with atropine and outdoors, which I didn't mention, one is that people are beginning to look at combination therapies rather than just monotherapies with myopia to try and get better efficacy with myopia. So the low dose atropine and outdoor and interventions and outdoors, so that seems to be growing in popularity. The second question, which is around looking at COVID times and progression of myopia. So We running what we call multi-ethnic studies. We've got groups of children that we've enrolled and we're observing in China, India, Vietnam, and here in Australia. And we happen to have some very limited data on children in China. And so we looked at their progression or the myopic shift in refractive error, because these were both myopic and non-myopic kids in what we call the COVID period and the non-COVID period. And we are finding that there is a 50% increase in the myopic shift in refractive error, as well as axial length changes. So both of them seem to correlate. But having said that, it's a very small cohort. So we are looking at that data a little bit more closely. But based on what some of the articles are saying, there does seem to be some shift in the refractive error.
So on behalf of our entire team at Sankara Academy of Vision, first of all, we wish you on the occasion of World Sight Day. And thank you and your team for the wonderful work that you're doing in this very important public health problem. And thank you so much for agreeing to be a part of this live stream series.
No, thanks so much for having me. Thank you. Bye-bye.